Can I get everyone? Can I get everyone to take their seats and we'll get started? And there are some, I know we like to sit in the, not at the very front, but there are some seats right here if there's some brave people that want to occupy them. All right, well, good morning, everyone. Thanks for coming to the fourth CHRISP working session. And my name is Nicole Yancey. I am a member of ECHO, and I'm the co-PI for the CHRISP grant. And what I want to first start with is to say welcome and to let you know kind of how the morning progresses. So after the brief introduction, we'll have our keynote speaker and some question and answer period. Then there'll be food, so there'll be a nutrition break. And then after the nutrition break, for those who have been involved with CHRISP from the beginning, I'm going to report on the community partner survey that we did so that there's some feedback there. And then I also want to start a discussion by showing some beginning themes that hopefully then will identify some research questions or ideas. And then we will break into groups after that and try and push those forward. So the whole idea with CHRISP is that after the year funding envelope, which is done the end of November, that we'll have some really strong research groups with identified research questions, and that then when CHRISP ends, that they'll continue. Okay? And these are groups made of community partners and researchers working together. All right, so, and also just to identify, we have our exits clearly marked for in case of an emergency, and washrooms are just through that back door on the left, and then you'll be set. So it is my very distinct pleasure to welcome Dr. Ian Janssen here with us this morning. Ian is a Canada Research Chair in Physical Activity and Obesity, and a professor in the School of Kinesiology and Health Studies and the Department of Public Health Sciences at Queen's University. We are very pleased that he's come because his research mostly examines the role that physical inactivity and obesity play in the development of poor health in both children and adult populations. And for those of us as researchers, he has a great funding areas. So his funding, he's received funding from the Canadian Institute of Health Research, Heart and Stroke, the Foundation and Public Health Heart and Stroke Foundation and the Public Health Agency of Canada. And I also want to thank our sponsors and our co-hosts. We have Human Kinetics from Laurentian University. We have the School of Nursing from Laurentian University. We have the Laurentian Faculty of Education and CIHR for the CHRISP sessions. And we are live stream. We have people joining us that aren't physically in the room. And I also want to say a shout out to Michelle Lawrence's class, who about 50 students are joining us right now. So without further ado, our keynote speaker.
All right, well, thank you for having me. I'm a graduate of Laurentian, that wasn't mentioned, from 1996, Human Kinetics. So it's great to be back in Sudbury. Thank you to Nicole and Alain and the rest of the group for their hospitality and for the invitation. And for the young people out there, I think I was first asked to come about 2 years ago. So it actually is a lot of work to organize these types of things. And so I hope that you recognize the work that's gone into it. It's just not, one person showing up and giving a talk. There's just tons and tons of work that's been involved for a long time to get this to happen. So they gave me this topic, and I said, I have no idea what I'm going to talk about. That was the presentation. So I said, well, I guess I could talk about a lot of things. So this is what I'm going to talk about here. I just kind of will get at the area of resiliency and physical health in children by basically giving you an overview of what the types of work that we do in my lab and how ultimately we're trying to prevent the onset or delay the onset of chronic diseases in adulthood. But we don't do this by studying old people, who usually are the ones that develop these types of things. We do this by studying young people, because all of the origins of these chronic diseases are in the early years. Unfortunately, in young people, you can't, look at the disease end. Well, fortunately, you can't look at the disease endpoints in young people, so you have to look at other markers that are giving you a sense of how well they are doing with their physical health. Things like their BMI or their waist circumference to measure their obesity, their blood pressure, which we hardly ever consider, cholesterol levels, things of that nature. To get them to do well with their physical health, we have to focus on their behaviors. In my lab, we focus on active living. We could put smoking in that box. We could put drug use in that box. We could put healthy eating in that box. There's lots of health behaviors that we can think of. I'm going to focus today on active living behaviors. And to change those living behaviors, we need to figure out how to fix the environments, both the physical environments that young people live in and their social environments. So I'm going to, over the course of my presentation, kind of talk about each of these boxes and each of these arrows as best as I'm able to in 50 minutes. So why do we want to study the grandson to prevent the things that he's going to develop when he's a grandpa, or the granddaughter when she's a grandma? Well, you don't just wake up when you're 70 years of age and develop heart disease. This is a process that starts when you were born. In fact, it starts before you were born. This here is a picture, an ultrasound picture of the artery leaving the heart. It would be the same if I chose any artery throughout the body. So the white part of the image is sort of the vessel wall, and then the black spot in the center is the lumen, or where the blood flows. And you can see in the lower right quadrant of that image, you can see this fibrous plaque developing. This picture, this image was taken in an adolescent. Okay? This was not taken in an 80-year-old. This was taken in a 17-year-old. And Gerald Berenson, who's done wonderful work in this area in Bogalusa, Louisiana, he's been able to do this in thousands of kids, and he's shown that already at the teenage years, you've got 32% of kids having fibrous plaques developed in their arteries. He's seen this as young as 3 years of age. And most 2- and 3-year-olds already have the early signs of vascular damage, fatty streaks and other things happening in their arteries. So this process starts, and then as that child there gets older, that plaque will get bigger, 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 and eventually it's going to occlude that artery, and that's when the heart attack happens, decades down the road. So we want to slow that progression. We're not going to be able to stop it. We want to slow that progression. The other challenge with why we want to study this in young people is often the road or the path that we take early in life is the path that we follow for the rest of our life. So it's very hard to go back to the start and then go down the right path. It's not always the case, but it's often the case. So here's an example with obesity. So this was work done in collaboration with Dr. Berenson's lab. So in this situation, we measured the BMI in a group of 10 to 12-year-olds. And we classify them as normal weight, overweight, or obese based on their BMI in childhood. We then measured these same young people 20 years later, so they were around age 30, young adults. And what we found is that almost all of the children that were, those young adults, the children that were obese remained obese as young adults, 80%. Not a perfect tracking, not a perfect correlation. But certainly, the things that are developing at young ages do track over time. This is true for the clinical risk factors and to a lesser extent with the behaviors. In other words, a child that's active is more likely to be an active adult. So that's a little bit about why we want to delay the onset of chronic disease by starting at young ages. Now I'm going to talk a little bit about these clinical risk factors here. And within that box, I want to talk a little bit about some of the surveillance issues. In other words, what's the magnitude of the problem that we see with these risk factors in children? And then I'll touch a little bit on the measurement issues. How do we measure obesity in kids, and why is it more challenging than it is in adults? And I will focus for the most part on obesity from that box, and that's simply because we have the most information there. We don't actually measure blood pressure a lot in kids, although I think we should. Let's see if I can take this out. So this should come as no surprise to anybody here. We've seen a tremendous increase in the prevalence of obesity in our young people in Canada in the past generation. This is data from 1980 through 2008. We see that the prevalence has increased from around 3% when I was that age to around 9% in our current generation of young people. So that's one generation, tripling. So who here likes the BMI, thinks it's a great measure? Nobody, not one person. Wow. Who here thinks it's a bad measure? Bunch of people. So what don't you like about it? What's something you don't like about it? Come on, I'm trying to get you engaged.
If you have a patient that's quite fit.
Ah, right.
Muscular.
We got these really muscular children all of a sudden, right? So all of a sudden, so there's lots of people don't like BMI because, we've got all these muscular people out there and it doesn't work. For surveillance, it works quite well, actually. There are certainly individual persons and people where it doesn't work well. You got Arnold Schwarzenegger, not the Arnold Schwarzenegger of today, the Arnold Schwarzenegger of 30 years ago. Those types of situations, but those are not extremely common. So in this study, what made this study a bit different is not only did we measure BMI, we looked at the waist circumference. And the waist circumference is actually a stronger indicator of their risk of developing cardiometabolic diseases. And it is not influenced by muscularity. You can do all the weights you want and your waist circumference is not going to go up. So lo and behold, the picture is actually worse with waist circumference. The prevalence went from 2% to 13%. Same kids that were studied with the BMI measures. These were the same people. So while we saw a tripling of obesity based on BMI, we saw a 7-fold increase in obesity using waist circumference. And if you're interested in eating this particular Whopper, if you were in Japan when they released Windows 7, you could have got that bad boy at Burger King, 2,500 calories. That's about 500 calories more than you need to eat in the entire day. So yes, BMI has its limitations, but if we used better measures, we actually would get a worse picture. And we've seen a change in the phenotype, both in children and adults in Canada, where for the same weight, children now have have bigger skin fold thicknesses, higher waist circumferences, and more fat than they did one generation ago. So the problem is not that we have more muscular children, it's that we have less muscular children today than we did one generation ago, and that's the main issue with BMI. The challenge when we measure the risk in a growing person is that we have to tease out the effects of growth versus the effects of abnormal growth. So what we see is kids grow, they mature, they get taller, they get bigger, they get heavier, their blood pressure changes, their blood lipids change, everything changes. It's not just their height, everything changes. And we often see this most often with the body mass index, and this is showing data for boys on the left and girls on the right. The different colors just represent children from different countries, both developed and developing countries, and from Asia, Latin America, North America, Europe. And you see that the pattern is the same. We see the first 6 months of life, BMI shoots up quite sharply. It then drops down until about age 5 or 6. We hit what's called the adiposity rebound, and it goes up. And that's irrespective of if you're a boy or a girl and where you live in the world. Girls, the growth trajectory is a bit different here than it is in boys because they mature at younger ages. And we actually use these types of growth charts to determine whether the child has a healthy BMI or an unhealthy BMI. Same thing for waist circumference and other measures. So this is an example of one system we use where the blue line represents the growth of a child that will end up having a BMI of 25 when they reach an adulthood. The yellow line represents the BMI of 30. So for instance, we would use BMI of 25 25 to define overweight at adult, we would use a BMI of 20 to define overweight for a 10-year-old boy, and a BMI of 24 to define obesity, because we would anticipate if that child grew as they were and matured as they were relative to their peers, that they would be obese when they became an adult. And there's all kinds of different classification systems out there. They're all a little bit different. I won't get into the differences between them. I'd be happy to have that discussion afterwards. Other than the point is that when we measure risk in a child, we have to consider their gender and their age. We're very familiar with doing that with BMI. This is also true with other clinical risk factors. This is showing a similar growth chart for triglycerides. This is the fat that's in your blood for adolescent girls ages 19 down to 12, and you see that same thing. There's differences depending on what age they're at. And I could put up HDL cholesterol, blood pressure, you name it, the risk factor. They're going to be different criteria that we use to define at-risk children depending on their age. So I'm going to spend most of my time talking about these upper two boxes. Physical activity and sedentary behavior is the real passion of mine. And in this box, I want to talk about some of the surveillance issues. How well are we doing in terms of getting our kids to engage in physical activity and limit their sedentary behavior? How do we measure these things? Because it's a real challenge to measure them well. And there's some exciting opportunities to measure things with the technology that we have. And how do these particular behaviors relate to those risk factors that I talked about earlier? So let's start with just some basic surveillance information on physical activity. And traditionally, the way that we measure physical activity in the types of work that I do, large population-based studies where we've got thousands of people, is we ask people about their physical activity. We have a series of questions that probes and prods about how much activity they do, what it might be, when they might do it, what the intensity is, things of that nature. And one of the studies that I've been involved with since 2002, it's called the Health Behavior in School-Aged Children Survey. This is a large representative sample of Canadian youth in grades 6 through 10, so approximately ages 11 through 15. And in each cycle, there's anywhere from 6,000 through 25,000 children of that age. And what we see is based on this self-reported data in different years, 2002, 2006, 2010, is that we have a very similar prevalence of children meeting physical activity guidelines. Unfortunately, the prevalence is very bad, less than 1 in 5. What was that sound? Unfortunately, the problem is even worse. Okay, this is no longer working. Is that what the sound was about? The pointer part's working. Oh, there we go. Okay, so unfortunately, we thought the problem was bad enough when we had the self-reported or the parental reported data. The problem became even worse when we actually decided we should objectively measure this behavior. And in the Canadian Health Measures Survey, which is conducted by Statistics Canada, they put on accelerometers, and I will explain that to you in a moment, to measure physical activity objectively over a week. And what we found in those surveys is that the prevalence meeting the guidelines was only around 5 to 7%. So you get very different answers when you measure a behavior versus when you ask somebody about the behavior. And you can imagine there's trouble with recall bias, as we say in epidemiology. It's hard to remember your physical activity. And there's a social desirability bias. You want to report things that are more favorable to the social ideal. And that's true of any behavior. So the way that we're now moving towards measuring physical activity is using things like pedometers and accelerometers, and we use accelerometers in my lab. This here is the accelerometer on this participant, and this is just a little device. It measures their activity, and you can actually measure it in units as small as 5 seconds, but typically it's done in 1 minute intervals consecutively throughout the week. So 1 minute throughout a week, that's 10,080 minutes of physical activity, or minutes of movement. So for each minute of the week, you know whether the child was sitting, whether they were at a low intensity, moderate intensity, or vigorous intensity. and it's hard to fool an accelerometer. You can maybe shake it, but even the kids get bored of shaking it after about a minute. Right? Maybe it goes in the washing machine or something like that, I don't know, but you can't fool the accelerometer. It's pretty hard to do that. And this would represent the type of data that you get from one child for one day for their accelerometer. So what we have here on the horizontal axis is the hour or the time of day. This child woke up at around 6:30, put their accelerometer on. They went to bed at around 9:30 at night, took the accelerometer off. And then all the bars, the spikes, just represent the intensity of movement throughout the day. So the higher the spike, the more vigorous they're moving. And once you get above that red line there, that means you've made the transition from being sedentary, what everybody in here is, except for me and the gentleman way in the back standing up. And if you don't want to be sedentary, I would encourage you to stand up and move around. You don't have to sit. I don't care if you stand. It's not rude. Don't worry. Once you get above the blue line, you've reached moderate intensity. And that's usually what we're interested in counting in physical activities, moderate to vigorous. And you could see how you could go through and count these little bits. Well, actually, the computer software does it because you wouldn't want to have to do that 10,080 minutes for thousands of people, right? The computer counts it up. You get a very good measure of how much physical activity they do. We're interested in figuring out how much kids need to do, what the intensity is, what the patterns are, and you can get at all of that really well with these accelerometers. So the first questions we have is how much is enough? How much do kids need to do? So here we're measuring how much moderate to vigorous physical activity they do on a typical day. It's measured with the accelerometers. And here's their risk of hypertension or high blood pressure. And this is the pattern we see, where you get the biggest bang for your buck by going from 0 minutes of activity to a little bit of activity. And here the risk was reduced by 50% when moving from 0 minutes to 30 minutes of moderate to vigorous physical activity. Some additional benefits, and then they really start to tail off after 60 minutes. And in fact, not very many kids are past 70 minutes. Here's the patterns for obesity measures, both waist circumference in the red and BMI in the blue, and you see the exact same pattern. Here's the pattern for triglycerides, exact same. And it's nice, right? When you have consistency, it's great. If they were different, it would really suck. It'd be really hard to give a message at the end of the day about how much you need to do. But when you say the same pattern over and over and over again, it's very easy to come up with a message about how much you need to do. So the other thing that we can get at with accelerometers really well is that the way that kids get their activity, and I think this is very important, because they accumulate their physical activity in very different ways than adults tend to do. So this, again, is the threshold here for moderate to vigorous physical activity. So when we get above the yellow line, you're moderate to vigorous. And we can see here that there's these bouts of activity. And this is what you would think if you went out for a walk or for a jog, it would be a bout, right? You're doing consecutive physical activity. And then we have this other stuff over here. Sporadic. We call it sporadic in my lab. And for most kids, 65% or more of the activity they get is sporadic. And there's some discussion about whether you need to do the activity continuously for at least 10 minutes before it provides health benefits, particularly in adults. The guideline actually is you have to do 10 minutes for it to count. So we were interested in knowing, does this sporadic stuff influence your health? And if so, does it influence your health to the same extent as this bouted physical activity when matched per unit time? So similar type thing as we had before, we have our volume of moderate to vigorous physical activity. In this situation, our outcome is the metabolic syndrome, and that's just a clustering of 3 or more of those risk factors, like you have obesity, high blood pressure, high blood sugar, things like that. So I'm going to start with the associations for bouted physical activity, and that mirrors exactly what we saw before, right, for total physical activity. And this is the association for sporadic. Like, I couldn't have drawn that line on there any better than what the data actually were. So this is very encouraging that we get very similar associations with health for this sporadic physical activity as we do for the bout it. And that's very encouraging because it provides us with different mechanisms for promoting physical activity in young people. It's also encouraging because, as I said before, for a lot of young people, the majority of physical activity they get, particularly young children, 6-year-olds, 7-year-olds, they're not out doing 10 minutes of continuous moderate to vigorous physical activity. They're doing play where they'll get a few minutes, then they'll stop, do sedentary or light, they'll get a few more minutes. The other thing that we're interested in terms of the patterns is, do you need to be active every day? Or can you take a few days off as long as your total volume of physical activity over the week is enough? So what we did in this particular study, again with accelerometers, is we have people that did not get 60 minutes on average every day, so we say that's insufficiently active. They didn't get 60 minutes on average per day. Then we had kids that got 60 minutes on average in these other two groups, the two active groups, but the first group might have only reached the 60-minute target on 4 or less days of the week. Okay, so maybe they got 90 minutes on Saturday, 90 minutes on Sunday, and then it went down during the week. So that they weren't getting 60 minutes every day, but their average was okay. Their weekly average was okay, or their daily average. And these are the kids that were getting 60 minutes, the frequently active, every day, at least 6 days of the week. So most days of the week, or all days of the week. And our outcome here was insulin resistance, and you don't want to be insulin resistant. You want to have a low insulin resistance value. And what we saw here is that those kids that were not active every day had the very similar insulin resistance values as kids that were not meeting even the 60-minute average. So there's something in kids where they need to be active every day, daily. We don't see the same things in adults, curiously. In adults, it seems to be just get your weekly volume up to at least 150 minutes, but kids are not just adults in small bodies. There is a different physiology there. So kids need to be active daily for optimal health. That's not to say that if you do 5 days, you're not going to get health benefits. Don't get me wrong. But for optimal health, we want kids to be active daily. So here's our physical activity guidelines for kids. At least, and that's what all of this information that I'm doing with the accelerometers is meant to lead into, what types of physical activity kids need to do? What do we need them to do for health? So kids should do at least 60 minutes of moderate to vigorous physical activity daily, at least some vigorous activity, and I didn't show you results, but vigorous activity, calorie for calorie, provides greater health benefits than moderate activity. Not time for time, calorie for calorie. There's some additional benefits for vigorous activity. We need to add some muscle and bone strengthening activities at least 3 days of the week, particularly for bone health. So this is weight-bearing activities, not just swimming will not do it. And more is better. In other words, if you do more than 60 minutes, you probably will have some additional health benefits. Now, there's great confusion over this 60 minutes, what this means. And when I say 60 minutes, and I get a parent will often say, well, my kid does soccer, and it's 60 minutes. They're meeting the guideline all the time. And I say, well, actually, how long was the soccer game? Well, it was 60 minutes. And I say, well, to get 60 minutes of moderate to vigorous physical activity, your kid needs to do 3 hours of soccer. Because they're not doing moderate to vigorous physical activity the entire soccer game. There's a halftime. Guarantee you they're not doing that moderate to vigorous physical activity at halftime. There's times when they're not actively engaged in the play. There's times that they're on the bench. So in most organized sports, only about a third of the time is spent actually doing moderate to vigorous physical activity. So it's not 1 hour of sport, it's 1 hour of moderate to vigorous physical activity. If you walk, and you do so continuously, that's 1 hour. So if you do 1 hour of walking, get a kid to walk 1 hour, please tell me how you're able to do it. I think I have a hard time getting mine to want to walk 10 minutes consecutively. You could do 8 hours of phys ed, 2 hours of DPA. That would take up your whole school day. That'd be great. I would have loved that. 3 hours of active play, or in a combination of the above. And that to me is ultimately what you want to do. So this would be an example of what a kid could do to reach the guideline. 20 minutes of DPA. 15-minute walk, so they could maybe walking to and from school, 60 minutes of active play, and that could include recess time at school as well as time at home outside of school. 50 minutes of hockey, that will be 60 minutes. So you got to be doing a lot of stuff, a lot of time to get to 60 minutes. And that to me is the most difficult part of getting people to understand the physical activity guidelines, is that with kids, they do not tend to do activity continuously. Moderate to vigorous, there's lots of breaks, lots of time that they are at a light intensity and sedentary. So they need to invest and spend a lot of time in physical activity to reach that 60-minute target. The other thing that the new message that's getting out there is that just because you get enough moderate to vigorous physical activity does not mean that you are still active enough. An active child can also be a very sedentary one. And I like to use this little analogy here where I break the day up: before school, school, after school, and after dinner, and say this is what a child might do. They wake up, they have breakfast and sit around. This kid's actually made the transition from sedentary to standing. Good for her. 60 minutes. And that would be, I think, what a lot of kids would do in the morning before they go to school. They get on the bus and maybe 20 or 30 minutes on the bus, and the majority, and I'm sure here in Northern Ontario that lots of kids are spending at least 30 minutes one direction on the bus. I had friends that went to my school that they spent 70 minutes each direction going to school. Catholic school in a rural area. 300 minutes of curriculum time, almost all of that is spent sitting, if not all of it. Maybe they get 45 minutes of moderate to vigorous physical activity through their phys ed, DPA, and recess time, because again, not all of the time that they have there is doing that. After school, of course, the kid comes home on the bus again. They, of course, have to catch up on their screen time. They have supper, then great, they go and have a soccer game. Maybe it's a 90-minute game and they get 30 minutes of moderate to vigorous physical activity. They, of course, want to drive to and from the soccer game, stop at Tim Hortons and have Timbits on the way home as congratulations for doing the soccer game. In addition to the popsicle that they're given at halftime of the soccer game. That's more calories than they expended during the soccer game when they do that. Come home and then, of course, have to spend 90 minutes telling their friends who weren't on their team about the soccer game through social media. So this kid, great, wonderful, 30 minutes, 45 minutes. They got 75 minutes of moderate to vigorous physical activity. Tremendous amount of moderate to vigorous physical activity. But look at all this screen time. Look at all this sitting time here. And think if we could replace some of this sedentary time, not with moderate to vigorous physical activity, with light intensity activity. You know, make your kids stand when they watch TV. I guarantee you their TV time will go down. Guarantee you it will go down if you say you've got to stand or do something at the television break. Replace some of this with just light walking to school or light walking to the corner store. Just spend some time outside. And even if you're not moving at a moderate to vigorous intensity, at least you are moving. And that's the message around sedentary behavior. It's not do more moderate to vigorous, it's do less sitting while you are awake. And for kids, it's particularly relevant for screen time. So here's our screen time guideline for children and youth in school. 2 hours or less per day of recreational screen time. That's television, computers, video games, and tablets and all the other stuff. 2 hours or less per day. This is how much the average 11 to 15-year-old gets per day. 6 hours and 30 minutes. That's more time than they will spend in the classroom in the year. They will spend in front of a screen. So when they tell me they don't have time to do physical activity, I say, well, I don't know, 6 hours and 30 minutes. There's a lot of television going on that you could get rid of. This is not only a problem in adolescence, it's starting to appear at younger and younger ages. This is some of our data out of Kingston. The guideline for preschoolers, this is ages 2, 3, and 4, is 2 hours, up to 1 hour per day. The guideline for children less than age of 2 is no screen time. It's 0. Okay, so we don't want kids being engaged in any screen time until they're age 2. Most kids start watching television by the time they are 6 months of age. And there's no benefits of that whatsoever. So we already got kids getting 1.5 times that in Kingston. And this is kids from well-to-do families that can afford to send their kids to licensed childcare centers. So this is, I think, the cream of the crop. I think if we had our disadvantaged children from poor areas in Kingston, it would be much, much higher. This is, of course, bad because we know that these sedentary behaviors influence our health independent of how much moderate to vigorous physical activity we do, as shown here. This is the amount of screen time, the risk of metabolic syndrome. It's the outcome, and we see here that as screen time goes up in these youth, this is 11 to 17-year-olds, the risk for the metabolic syndrome goes up. And most Canadian kids would fall in this group here, where risk is increased 2.5-fold. Most Canadian kids would fall there. Not too many falling here. We're now starting to get at what form of sedentary behavior is the worst, or what forms we need to be worried about. In this particular study, we have television, computers and video games, and then total sedentary time as measured with the accelerometers. So this is total sedentary time. So this is TV. And we see with TV, it's the same as we saw in the previous graph, right? And this is computer and video games. And we see no association for computers and video games. So what is it about TV that you think is different from computers and video games, and why it might be associated with, in this situation, obesity, the metabolic syndrome, hypertension, things like that? What is so special about TV? What are you doing when you're watching TV? Yeah, it's a little bit more sedentary, so you're actually expending less energy while you're watching TV than doing these other things. And then it's eating. When you're at the TV, your hands are usually free, and children are not eating carrots and celery, and they're eating snacks, potato chips, cookies, things like that. And you're being bombarded with lots of TV advertisements about food products and beverage products. So we think that's probably the mechanism by why TV seems to be worse than these other forms of sedentary behavior. Interestingly enough, we saw no association with total sedentary time. There's been a number of other studies that have come out since this showing the same thing. So it seems to be that TV, for whatever reason, is a really bad sedentary behavior to be engaging in, much more so than other sedentary behaviors. I don't want to show you what the association is for homework and reading. Doesn't get a lot of people excited, I'll just say that much. So now I want to talk a little bit about the environments. How much time do I have? About 20 minutes? A little bit about the environments, because ultimately if we want to change the population level, we want to change these behaviors here, and ultimately these outcomes down here, we have to change or think about the environments. And it gets really convoluted here, because when you think of a young person, you got to think of their environment at home, you got to think of their environment in their neighborhood. And for a young person, that's about 1 kilometer around their home. Because for a young person, they're usually only allowed to travel about 1 kilometer from their home on their own, without parental supervision, right? So we call their independent mobility. What was your independent mobility? Probably in Owen Sound, you could have gone anywhere when you were growing up, right? We talk about their school, and that may or may not be in their neighborhood. I would say for about 50% of Canadian children, their school falls outside of their home neighborhood. And we could talk about the community, which is sort of like the greater Sudbury area. And all these environments are potentially important. And then we could think of all kinds of things that we could measure in those environments. We could measure features of the built environment. We could measure features of the social environment, their relationships. And, if we could study everything in this grid if we wanted to, and lots of things would be important. And I don't have time today to go through the entire grid. So what I'm going to do is talk a little bit first about some of the features of the built environment in the home neighborhood, because that's been a real focus in the research, including my research in the last decade. And then after that, I will talk a little bit about the social environment at home and how that is important. So let's start with looking at some of these built environment features of the home neighborhood. And this is the first paper I ever was involved with on the built environment and movement behaviors in kids. And we had to scratch our head after doing this one, I'll tell you that much. So what we were looking at is the density of recreational facilities. This is things like arenas, community centers, gyms, things of that nature, in the children's home neighborhood, ranging from the lowest quintile to the highest quintile. So this is the lowest 20th percentile, the highest 20th percentile. And we're looking at their odds ratio for getting at least 4 hours of activity outside of school hours during the week. And, you know, perfectly flat. Perfectly flat. No association whatsoever. And this is like, we're doing this at a time where everything in Canada was around building more facilities, building more facilities, building more facilities. And we've repeated this in other samples, same thing. Repeated it 3 times, 3 different groups of 10,000 to, 6,000 to 25,000 kids. Exact same finding in every sample. Nothing going on there. We've looked in a series of studies at outdoor play spaces. We started with looking at parks, again, something that's received lots of attention in a lot of communities. And this is looking at the lowest quartile versus the highest quartile. And we see with parks, there's no significant association. In fact, the third quartile was the worst. With cul-de-sacs and undeveloped green space, this is like fields and wooded areas, we saw that there was an association. And this receives no attention in the built environment literature, no attention by city planners. Yep.
So you were just looking at the density?
Density.
Numbers, so you didn't really look at patterns of use?
No, we're just here looking at how many cul-de-sacs in your neighborhood and in this situation, and how active are you outside?
Because I would automatically just guess that, because of the culture of paranoia.
Oh, you're like already 5 slides ahead of me, so yeah, you're perfect. So I can skip those slides, great. So you ruined my punchline, though. Okay, so why is it that why is it that park space and recreation facilities aren't associated? Well, we have saturated our environments in Canada with these things. You ask parents in Canada, are you happy with your parks, the availability of parks and recreation facilities? And almost every one of them says yes. In the city of Kingston, where I am from, I said yesterday, we've invested over $100 million. This is a city of 150,000 people. We've invested over $100 million in recreational facilities. 6 ice pads, 2 swimming pools in the past 5 years. We've invested probably $30 million in parks in the past 5 years. And I'm not saying that we don't need to have these things, but if we think that just if you build it, they will come. That's something, the line that appeared in one of the very first built environment. If you build it, they will come. And in Canada, if you build it, they might not come. Because we actually have invested a lot in our built environments in those ways. What we need to do more work on is the programming that we have in these facilities and making sure that they meet the needs of the people who we want to use them. Same thing with the parks. This is the park that's directly across the street from my house that services my neighborhood. And I live right across the street from this. I'm outside all the time, my kids as well. So I know what happens at this park. I'm like the park monitor. So if you were an 8-year-old, 10-year-old, what would you do at this park? Not go there. And you don't see anybody there, do you? It basically suits 2-year-olds to about 7, 8, maybe 8-year-olds. But once, and even my 3-year-old and 5-year-old, after about 10 minutes, they're pretty bored of that park. It's not very challenging. It's like, well, I'll go on the swing. Yeah, I'll go down the slide a couple of times. I'll climb the little artificial rock wall. Okay, I'm done. There's no room to do anything. There's no room really to run around. Yep.
I know this from the U.S., but we're also living at a time where a woman got jail time for allowing her 9-year-old to play
Yep.
with themselves in a park. So
You're like 5 steps ahead of me here. So I think you've seen my presentation before, or I emailed it to you, right? I just want to talk about the presence of these things, and then we're going to talk a little bit down the road about some of the fear and the paranoia. So I talked about that yesterday. Yeah, there was a woman in California, brought her kid to work with her, and there was a park next door, let her kid go to the park, and then somebody phoned child services and the police, and her child was taken away from her. Woman let her child play outside in the driveway in Texas, same thing. Neighbor calls the police, child taken away. So there's these stories and paranoia and whatnot. So here's the other play spaces that we did find, that we are finding, and these are things that people are not thinking about. wooded areas in particular we're finding, and whether that's just they're actually using the wooded areas, I don't know, or it's just a feature of the neighborhoods that they're in. But this is a very stimulating environment for young people, and you go in the wooded areas near my house, people say, you're very lucky to live beside the park. And I say, well, it's not luck. That's one of the reasons we moved into that house. And I say, we're more lucky to have 6 acres of unprotected wooded areas 1 block from my house with trails. It's actually part of our subdivision that they never developed because there's some issues with the water and the rocks in there. It's kind of like Sudbury, you know. Do you want to invest $1 billion to blow up something to build one house? Probably not. Cul-de-sacs, and Alain was talking about this yesterday with his kids. He said everybody goes to the goat chase house and plays outside on the road, and he said they got a beautiful backyard, nice level grass, fenced in. He said nobody wants to go back there. They want to play out in the street. So these quiet cul-de-sacs, dead-end roads, things like that are play areas for young people. And not a lot of cars on those things either, right? So let's now move to walkability, and this is when we start to get into your concept of fear. So walkability. So here's on the right in the blue box, highly walkable neighborhood. The picture at the bottom is sort of your aerial view, satellite picture, and the picture at the top is the ground level picture. Pictures on the left is your non-walkable neighborhood. A lot of attention to this in the adults, about how living in this walkable neighborhood is good for your activity. And how do adults tend to get their activity? Most adults get their activity walking, right? So it makes sense. You want to go from point A to point B, direct linkage, grid-like pattern on the streets. It's very efficient. Where you want to go to A to B here, it's too far. People don't want to walk that far, right? And you go, and here, there's places to walk to. Here, you can only walk to houses. There's nowhere to go. So in adults, there's very clear evidence that living in this type of neighborhood here promotes physical activity. And a lot of movement to design neighborhoods in this way, in particular in the United States. So we were interested in looking at that in Canada. So we first looked at how well the streets connected. Did they have the grid pattern, or did they have the cul-de-sac pattern? And we looked at kids' activity levels outside of school. And I could put active transportation here, and you'd see the same thing. And lo and behold, we found the exact opposite to what you see in adults. Kids that lived in the most highly connected street neighborhoods were the least likely to be active. Least likely to be active. Particularly if it was really highly connected. And we thought, well, maybe we got to look a little bit beyond just the connectivity. So then we said, let's measure the walkability, which is a function of the connectivity. Are there sidewalks? And is it mixed land use or only residential? So it's a really comprehensive measure of walkability. Different sample entirely. Same pattern. Same pattern. So let's go back to these pictures. So, you know, what concerns you about the picture on the right? Right, like it's hard to see here, but there's all these people on the sidewalks, right? And when you don't know those people, they're called strangers. And parents are very worried about strangers, right? Very, very worried. Even if there is not a problem with child abductions by strangers in Canada, I'm not going to show you the evidence today. I showed it yesterday in my presentation. I think the last child abducted in Canada, and its stereotypical child abduction was Tori Stafford. That's probably 5 or 6 years ago. These things just don't happen. People that are kidnapped by their parents or somebody else in their family or somebody else that they know. What else concerns you about this picture on the right? If you were a parent of a 10-year-old and the cars, there's just a lot of cars, a lot of traffic out there. Not a lot of cars in here because you don't drive down dead-end streets, and if you do, you probably know that neighborhood and that you know the people that live there, and you know that there might be kids out there playing. So it's only the residents that live there, and you're driving slower because there's lots of curves and things like that. So it actually is a traffic calming mechanism to live in a neighborhood like that. And parents are scared of cars, and they are scared of strangers. Even if the number of kids getting hit by these cars is extremely, extremely low, you're far more likely to die being a passenger in a car than being somebody walking on the sidewalk or somebody on their bike. And as I said before, kids are not getting abducted in Canada. We also are interested to a certain extent in looking at, does it look like a nice neighborhood or does it not? And this, again, comes from the adult literature. So we call this aesthetics or physical disorder. And these are, this picture on the left is about a 2-minute walk north of my office. And this picture on the right is a 2-minute walk to the east of my office. And they're two distinct neighborhoods. So you probably, when you lived in the Princess Towers, you would have walked by this house, this place all the time. It's about, and you can see, here's the person outside smoking their cigarette. Here's broken furniture, the recycling scattered all over, paint's coming off. This is their beautiful flower garden here, or weed garden, graffiti, grass is trampled, because students, of course, will make the shortest route possible. They can't walk over here, they gotta walk right there to save 4 steps. Then this pristine building, just meticulous. And you've got to have about $1 million in Kingston to live in this place, $1 million to buy this place here. Doctors, lawyers, people like that, not university professors. Beautiful flower gardens, well-maintained grounds, right? So we say this has got a lot of physical disorder, this one does not. And what we find is that the really bad areas with a lot of physical disorder, a lot of, just doesn't look nice, they're more likely to kids inside watching lots of TV, and it makes sense. You just don't feel safe letting your kids outside when it doesn't look safe, it doesn't look nice. And what we also found, I'm not going to show you here, is this really interacts with the social disorder, our social conditions of the neighborhood. In other words, areas where there's physical disorder were not a problem if there was not a lot of social disorder or social deprivation. By social deprivation, I mean there's unemployment, higher crime rates, people moving in and out of the neighborhood, lots of single-parent families, things like that. It was only an issue where there was a combination of physical disorder and social disorder. And really, we think that it's this fear. As you said, it's the fear. It's the concerns of safety that are really driving whether kids are outside using these neighborhoods for physical activity. These are the things that we have found in a whole bunch of studies that relate. Lots of roads and lots of people. Bad. Not a lot of traffic calming. Bad. Not a lot of sidewalks. Bad. Physical and social disorder. Bad. Particularly social disorder. Perceived unsafe, irrespective of whether it is safe or not, is bad. So I want to talk a little bit about that last point. So this is some of our other data. And here we have the youth's perceptions of safety, and we ask a whole series of questions like, is it safe for young kids to play outside? Can you approach a stranger and talk to them? Things like that. And you see this beautiful relationship. Beautiful in a sense that it's good to look at as an epidemiologist, not beautiful in the sense that, when you perceive your neighborhood as dangerous, you're a lot less likely. In fact, only about 1/4 is likely to be active in that neighborhood. This is our objective measure of crime. Not nearly as consistently or strongly related as the child's and the parent's perceptions of danger in that neighborhood. So it's really their perceptions of danger that are important. So if we want to change these neighborhoods, we got to make people feel safe in these neighborhoods. Not necessarily actually improve the safety, make them feel safe. So now I want to talk about the family and the home. And I think I have about 10 minutes, 5 minutes? 10 minutes? Okay, perfect. It's family and the home. So, and particularly about the roles of parents. And you'll have to excuse me, I'm a relatively new parent, so I'm very much personally involved in this discussion and debate, as probably stems my evidence more so than the actual science. And the parents are very important. They can facilitate their child's activities. In other words, they can pay for sport fees, they can drive their kids to practice, things like that, right? They can encourage their kids to be active, like go outside and play, it's good for you. Don't watch the television, go outside and play, it's even better. Things like that, right? They can engage in physical activity with their kids, go for a walk with them, play with them, heaven forbid. And they can be active role models. In other words, I tell them, I'm going out, Daddy's going out for a run. So, you know, he's going to get his exercise. It's good for him. So you need to go out and get your exercise. So you're an active role model. And we know that all of those types of things that parents do would promote healthy living in their kids. Okay, there's good evidence of that. We also know that to a certain extent the socioeconomic conditions of the family will influence those things. In other words, you know, children from more disadvantaged, poor homes, their parents would less be likely to do those types of things. And children from homes with single parents, things like that. So those types of things that you know are related to everything, right? They're related to everything in a negative way, the socioeconomic things. They are relevant for this as well. I'm more interested as being a parent and looking at how the parenting practices that one uses or the parenting strategies that one uses influences that and the way that you parent and the way that you go about doing it. And I've noticed a lot in my own career as a professor and also just by looking at other friends and how they parent their children that there's a lot of these what I call hyper parents out there. So you're probably familiar with the helicopter parents as shown in the top left, and this is parents that they like to protect their children from all evils of the world, all dangers, and if their children has a problem, they immediately come to the rescue and solve it for them, right? We see this in university where you get emails being sent to your dean on behalf of the student from their dad because they weren't happy that you penalized them on their assignment for being late. That happened to me a couple of years ago. Only time I ever got a phone call from my dean in 10 years. We have little emperors and little empresses, and this is where the parents want to give them everything they desire, right? You want that toy? Here you go. You want that toy? Here you go. Right? We have tiger moms, and she called herself the tiger mom, Amy Chow. She's actually a professor at Stanford, and she would accept nothing less than first place, nothing less than straight A pluses. If their child was in grade 5, they should be at grade 8 level in violin, you know, exceptional achievement. And they push their children towards exceptional achievement. They are relentless taskmasters, relentless. And concerted cultivation. This is where your kid is enrolled in everything, sports included, but band, drama class, this, that, and the other. They're just inundated with activities. They got a private tutor. And all of these things are done with the best intentions, right? You're doing them to give an advantage to the child. At least you think to give an advantage to the child. And there's been a lot of debate in the media and in the research circles about whether this is in fact giving kids an advantage by hyperparenting. Is this good? Is it indifferent? Or is it bad? So there's ways that you can measure this. There's scales to measure these things. So we've just done a study, and this is under review, so it's not yet published. I hope it will be published soon. And this is the hyperparenting score, so ranging on a continuum from, you know, the least use of hyperparenting to the most use of hyperparenting. And what we see here is that those that engage in very limited amounts of hyperparenting, children from those types of homes, engage in more active play, more active transportation, which I'm not showing here, than children that live in homes where there's a lot of hyperparenting. And think about it. If you're a helicopter mom or dad, are you going to let your kid go outside and play by themselves? No, you got to be there watching them, right? If your kid is engaged in 25 million activities, do they have time to be a kid? Is there time for them to actually walk somewhere? Is there time for them to go outside and play catch instead of just going and playing a baseball game? Probably not. That's what we think anyways. So sometimes when it comes to parenting, less is more. Less is more. For young kids, parents are even more important than they are for adolescents and older kids. That particular previous study was on 8 to 10-year-olds. This is on 2 to 3-year-olds. And we're looking at predictors of TV use in these 2 to 3-year-olds. And 17% of the variability in that behavior we were not able to predict with our variables in our model, but we were able to predict the remaining 83%, and we were just absolutely thrilled with that. If you can predict 83% of a behavior, I was like running and cheering like I just won the Olympic gold medal in the 100 meters. And I was running faster than Usain Bolt at the same time. 25% we predicted with interpersonal factors, how old the child was. The older they are, the more they watch. Boys more so than girls. 8% from the environment of the home, particularly television in the bedroom, and 18% of these kids at age 2 and 3 had a television and or a video game console in their bedroom. That's like giving a kid a pack of cigarettes as far as I'm concerned. You do not put a television in their bedroom at any age. And 50% were all about the parents. Did you live with one parent or two parents? In particular, was 8%. And what were the parents' own beliefs and thoughts about television and screen time? Did they understand that you should not be putting a 2-year-old in front of a TV? Did they think that you would learn by putting a 2-year-old in front of a TV? Did they think that it was a good idea to let a 2-year-old watch television so that they could get stuff done around the house? And that's what 88% said they did it, is because they said it allowed them to do things around the house. They could cook their supper, do whatever else they needed to do. So it's really all about the parents and what they thought and how difficult they thought it would be to get their kids to change. A lot of them said they couldn't get their kids to change because their kids liked it too much. Like, my 2-year-old likes to eat candy. My kid was 2 when I did this. I say, I don't let her eat all the candy she wants. It's pretty simple. I'm the dad. She's the kid. It's pretty simple. Just not give her the candy. With my kids, I say the remote control is way up here. I want to see you get that remote control. My son has now discovered that he can use the stool, so it's a bit of a challenge, but it was great when he didn't realize that he could use the stool. Okay, I'm going to wrap up now. So hopefully I've been able to convince you that to prevent people from getting sick when they're 60 and maybe prevent that until they're 80, delay these types of things that are the leading causes of morbidity and mortality in Canada, we need to start worrying about these things when people are born, not when they're retired. That in young people, we've got to measure, we can look at the early markers of these things, such as their obesity, but there's other things we can look at in addition to obesity. Obesity is not the be-all and end-all of health in kids. It often is presented as that way, but it is not. And I'm the Canadian Research Chair in Physical Activity and Obesity, and I am saying that, okay? It is not the be-all and end-all of child health. It's one thing of many. To get kids to be healthy, we got to get them to be active. And again, we got to get them to eat well. We got to get them to not smoke. We got to get them to not abuse drugs and alcohol, things like that. All kinds of other behaviors that are not of interest to me personally, but are extremely important. And ultimately, we've got to work on changing the environments that they live in, go to school in, and play in. And you're very happy because I'm now done. Thank you for your attention. And how long do we have?
I guess I said I should roll it up. Okay, well, thank you so much. That was, I know I was taking notes madly. What I would like to do now is we have some time for question and answers, and just so we get a chance, I want to make sure, are there any that came in on the CHRISP website or on the CHRISP email site from people? Okay, so yes, we have some virtual questions here. So
Virtual people are more likely to ask questions than real people.
okay, so we have one question. Oh, thank you. So it is from Michelle Lawrence in the School of Human Kinetics. That's a professor of whose classes have watched this. So it says, I'm an instructor for PhED, physical ed. Thank you, physical health and education. Human growth and physical activity class in the School of Human Kinetics. We are studying the role of the long-term athlete development model and its role and effectiveness in developing physical literacy in children and youth. Clearly, do you want that one? Okay, we have a word here. Clearly, it and resiliency go hand in hand, yet both are slow to be acknowledged in certain circles. In which circles, schools, sports teams, government, industry, universities, do you think these principles would be most effective? I guess we are asking, how can we get this message out and get kids moving? Thank you for your visit and response. Do you want to see the question?
That's a real easy question to answer. There is no easy answer to that question, and I don't, when people say, should I do this, that, or the other thing, I usually say you should do all three. That's usually my response, is that with something like changing a behavior, it's always 1,000 times more difficult than you think. So just by saying focusing on schools or focusing on home or focusing on government, or you can't focus on any one thing. You've got to hit everybody. Right? So with a lot of things. So it's, I will just mention that there's a new initiative launched by the Ministry of Health and Long-Term Care, and I think they're investing about $35 million in this, would be my guess, but Sudbury is going to be one of the communities involved, and it's called the Healthy Kids Community Challenge. So Sudbury is one of the communities, the greater city of Sudbury is how it's recognized on the website. And I imagine they will be getting upwards of $1 to $1.5 million over 5 years on childhood obesity prevention initiatives. And it is truly a community-based thing where you're trying to develop partners with everybody. And you're not leaving out any of those sectors or any of those things. You're developing partners with industry, with the food industry, with the government, with recreation, with schools, with Laurentian. And I know that Laurentian has wrote letters of support for that. So you've got to work with everybody. The right hand has to know what the left hand is doing. I don't know if that answers the question. I hope it does. I don't know if they can hear you on the web thing.
Oh, okay. I was interested in the data you were looking at that showed the bouts of exercise and the sporadic exercise, and particularly around the sporadic. I'm wondering what kind of patterns you're seeing. Like if they're sort of happening sporadically, but within a period of time or throughout the day. And I'm going to add on to that because we're trying to figure out a little bit around the school scheduling. And I wonder, is it, we're sort of postulating that it's more important to have more recesses for shorter periods of time throughout the day rather than a longer, like an hour break. And with your, with those kind of two connected thoughts, can you comment on that?
Well, it depends on what your objective is. Is it just to get the kids more active? Like for me, when my kids had to go to school, I'm like, I don't know how they're going to sit there. It's like 100 minutes on, then the 40-minute break, including 20 minutes of eating, 20 minutes outside, then 100 minutes break, and then 100 minutes. And I go, I don't know how my kid, my daughter's 3, she turns 4 in December, I don't know how she's going to sit for 100 minutes because they don't watch TV, like maybe half an hour a week at the most. They're not, how is she going to sit for that? So I think that for a lot of kids, like for educational wise, I could see from the teacher not going completely insane, how breaking it up from that standpoint would be good for their attention and things like that. Because even in a university class, I teach a 3-hour lecture. 45 minutes I have to stop because first off, I can't go on longer. And the students are just about ready to strangle me because they need a break. And that's, 20-year-olds. So I personally would favor, I think from an educational standpoint, from what I know, it's better to have more frequent breaks. But we see all kinds of patterns in the kids. It's like you look at one profile and they're sporadic in one way, another kid is sporadic in another way. So there's no, it's all over the map. And we haven't really been able to say, this is a kid that's kind of sporadic within an hour-long block versus a kid that is just like sporadic throughout the whole day, matched, for total sporadic. Because it's just all over. It's a continuum. It's not like you fit one pattern or you fit another pattern. It's this whole continuum of that. And I just say more is better. So just get your activity and sit less.
Thank you.
Yeah.
Can I just add on to that question?
But if anybody, maybe the teachers can.
This one apparently is on.
So has anybody started to think about developing sedentary behavior guidelines for school time? Because I understand that 2 hours is after school time, but there are no guidelines for teachers within school.
There are no guidelines because there's not enough evidence. So if you notice, if you've ever looked at the sedentary behavior guidelines, there's a strict criteria for screen time, 2 hours or less per day. This is for school-age children and youth. And then it's like, limit the amount of time spent sitting and spent in motorized, I don't remember the exact words. And I was part of the panel that put those guidelines together and looked at the evidence. And there's just not enough evidence on how little sedentary time that kids should be getting. It's just, it seems like there's this effect. So to then say, what should we be doing in the school day? We just don't know. There's lots of interventions going on, particularly in Australia, around things they're doing, like they're putting in standing desks in schools. They're doing things like this. They're having more frequent movement breaks where it's just 2 or 3 minutes and things like that. And they are showing some positive effects on sedentary behavior and the attention. I think the attention and the behavior. Because I just don't think that kids like to sit for long periods of time. It's just hard to concentrate for that long. But it's not my area, like that is not my own area of expertise, so I'm limited in knowledge.
I really enjoyed your talk, Ian. Thank you very much. I just have a question with regards to the physical and health education classes. So again, physical activity within the school setting. With your accelerometer data, have you seen a difference if the teachers are trained phys ed teachers as opposed to non-phys ed?
So yesterday I showed a slide, and it was out of BC. They were doing the Act Now BC campaign, and it was traditional, regular classroom teachers, and 75% of the time was spent sedentary in a PE class, and only about 12% of the time was spent in moderate or vigorous physical activity, because it's a lot of sitting down, a lot of instruction time and a lot of standing in line, and it's not meant to move the whole time. But there's been comparative studies where they compared, trained specialized teachers to the traditional or just regular classroom teachers, and the profile is better. Is it fantastic? I don't know, but it's better. I would say there's probably 20% more movement when I look at it in the trained specialist than with the general classroom teacher. And I know at Queen's, when they're doing theirs, they're given, I think, if they're given 1 unit of science, of math, they're given half a unit of PE, and that might be the only PE they're ever taught in their entire 5-year university education, is that 1/2 unit in their education year. And most of them have not taken PE, a lot of them, since they were in grade 9, high school. I guarantee you, they took science and math and reading all the way through.
Is this one's on?
Going now. Okay.
All right, thanks. So I'm an instructor of wilderness medicine at Canadore College in Parry Sound. And I recently graduated from the Bachelor of Education program at Nipissing University. And if less is becoming more, and there's a greater unimportance on the environment, how do we keep kids going to camp? And how do we keep camps that are operating out of the red line?
Well, less is more when it comes to building things and taking away from nature. I think more is more when it comes to getting kids into nature, but, and we were talking a little bit about this before. There's this whole big thing now, the Nature Alliance of Canada, and the gentleman's name that runs that, his name is Nick. I can't remember his last name. And this is where a lot of my thing is, we need kids to get outside, and outside period, but particularly out into nature and doing the types of things that you do. And we've really, a lot of kids just have never had that personal touch with nature, to be honest. And I have kids in my classes, and I guarantee you they've never gone on a camping trip, been in a canoe even probably seen a canoe. How do we keep those places? So I don't think it's less is more when it comes to that. I think it's less it's more when we think we got to build things and take what I call natural space and make it into a developed park. Sometimes maybe we got to put a trail in there or get people to get access to it, but do we need to go into an area where we're developing, clear cut the subdivision space, take out every single tree when they build a subdivision, and then they plant new trees. I'm like, why did you take out all those trees that were there? Just build around them. They take out every single tree. Then they put in this tiny little park that's about the size of this area here. And they put in about 10 of those things. And I'm like, why didn't you just have one great big huge park in the middle that left some of the trees in the natural space. But how do we keep these things out of the red? We got to get people to want to use them. But I'm not, you probably can answer that. You can answer that. I don't know how to answer that question. Maybe.
No, I mean, I had a similar question about the built environments and, should we be leaving more undeveloped space? And I think you just addressed that. It's quite obvious.
So Jim Salas, who's done tremendous work on the environment and is the guy when it comes to the built environment, and he's the one, if they build it, they will come. And has anybody ever read what's the book? Nature. What's the name of the book though? Richard Louv. Last Child in the Woods, right? So there's a nice piece in there where he said he talked to Jim Salas about this, like why aren't people studying the natural environment as it relates to physical activity? And he said, well, there's no money there. There's no money. So people don't want to fund it. So I'm like, well, that's just, so I actually read that book and it was an awesome book. So I'd encourage anybody to read it. And I said, well, you know what? We're going to measure this. I've got funding to measure, and mine was just measuring the environment. It wasn't the built environment, my grant. So we measured it. And it was a pain in the behind to measure that stuff. Because there's databases of roads, there's GIS databases of everything, but then they just call it green space. And you're like, well, is it green space that kids can get access to? Is it, so we had to go in and it took a long time for us to figure out these are things that kids can get access to that are natural spaces, undeveloped natural spaces, that are not publicly owned spaces like wooded areas, things like that. It took us more time to measure that. We could measure the parks in the entire country in the morning and assign that to all of our 26,000 participants. It took us 3 months to do what we could do in the morning to do for natural spaces because there's not the databases of it. So it's very hard to measure because the database, they don't measure it in the way that we want to measure it for kids to being able to access it. It's just green space. And that could be anything that's green. So, it's under review right now. But I was just shocked when we say we can't find an association with parks, but we find this association with natural space. Undeveloped natural space, as we call it, particularly the wooded areas. Not the fields, the wooded areas.
Hi, I'm Roberta Heel. I'm with the School of Nursing, but I'm also a primary healthcare nurse practitioner. So you get a baby into the clinic, into a family practice clinic, and what you do is height, weight, head circumference, because and they're charted on a percentile, and you ask them questions based on standards about the activities that they should be doing at those ages, but they're developmental issues. What I found is, as children get older, it's almost impossible to convince parents that their children are overweight. And I'm thinking, and then if you do, you say, look, the percentile, they're way up here, they argue with you that they're big boned family, that sort of thing. So what I'm wondering is if there is any thought or perhaps an integration of, as the child ages, to include something like a BMI and a waist circumference plus questions about their activity that are prompts then for the healthcare provider to ask those questions and then to give counseling to the parents and to demonstrate. I can tell you sometimes by showing them the paper that this is a standardized way of assessing a child in this age group can sometimes make a difference when you're trying to counsel them about the kinds of activities that the children and stuff should be involved in or foods that they should be eating. Oh,
I'm a strong believer that you want to know about the behaviors, and then the BMI is one of many, as I said, it's one of many things that's telling you about the health. And that to me, I would rather than measure the physical activity, measure their eating, measure their, some questions about very simple things, about activity, eating, all those types of things that measure their BMI in the doctor's office, in the primary care office.
In the nurse practitioner's office.
Nurse practitioners, whatever.
Just saying.
Doctor, nurse, healthcare, primary care setting is what I say, the primary care setting. I would rather all those things, and the Rourke scale and all that, and I'm looking at it going, well, yeah, it's not really getting at what it needs to.
But isn't there a perfect opportunity then to integrate the developmental plus the lifestyle, if you will?
There's an opportunity, and I would love to see that.
Okay.
that opportunity be used. So please, nurse practitioners, do that. If they want my help in saying what questions they should, I would be happy to provide some support. And I, you know, in the same, even at adults, you know, they measure the height and weight. Okay, you're obese. And the message, just eat better and exercise more. I'm like, oh, that's what the message would be. It's not, you know, how do I actually get you to eat better and exercise more? Yeah. Yeah.
Oftentimes they don't believe that they need to make a change until you show them the numbers.
Yeah.
So I've found that with parents too, showing them the guide, saying, look, this is your child's height and weight, and we need to work on this, sometimes makes a difference.
Yeah. Yeah, but you know, it's very sensitive around body weight. It's the most, I think, sensitive issue for a lot of people for good reason. And it's a very, very difficult issue to tackle one-on-one, let alone in, you know, when I do population-based stuff. And it's you have to be very sensitive, you know, use the right terms. And it's very difficult. And there's lots of issues, there's lots of publications around that, mostly in adults, about how do you actually even open up the discussion about that. And there's the 5 A's for, if you go to the Canadian Obesity Network website, there's the 5 A's for obesity management, and they have one for kids now, pediatrics. So the first question is, the first A is for ask. And that is, are you comfortable having a discussion about this issue? That's the first question. And if they say no to that, then there is not really a discussion that goes on.
I actually, sorry to keep going, but I was at a talk about with a pediatrician who works with children with obesity, and she said, you are negligent if you don't approach the parents about the issue.
Well, that's what I say. That's what the A is. It's the ask. And you've got to ask and start to have the discussion. And then if it's a no, then you got to say, well, I want to put this on the table, and maybe the next time you're here, we'll bring this up again. But, you know, it's like, why bother going at it if there's no way that they're going to even be comfortable having a discussion? So it's a really good, and there's all kinds of materials on that about how you do the weight management for kids, pediatrics, and all the big gurus on this in Canada, J.P. Chenois, Catherine Morrison from McMaster, Jeff Ball from University of Alberta, all the people that deal with the clinical aspects of dealing with children with obesity, and that's not what I do. They're the ones that put this together based on an adult model that's been modified and adapted for use in children. Now, they're primarily dealing with specialized clinics, so it's a bit different in primary care and in the patients that you'd be dealing with, but it provides a good framework, and it's all free, and lots of materials and resources.
Hi there, my name is Penny Sutcliffe, and I'm the Medical Officer of Health with the Sudbury District Health Unit. I also had the privilege of sitting on the Healthy Kids panel, the provincial panel that received and reviewed many pieces of evidence and research, including your own. So thank you for your talk. I've learned lots, and I felt like I was immersed in this for over a year. So I've learned lots from your discussion today. Thanks for bringing us together. My question is around the input side of the equation, so the food side of the equation. Mm-hmm. And on the Healthy Kids panel, after reviewing all of the literature, we really understood absolutely the contribution to health of the physical activity side, and certainly the environmental side, et cetera. But really came to the conclusion that we needed to perhaps disproportionately invest on the input side in terms of our understanding of the contribution of nutrition, poor nutrition, overnutrition, et cetera, to obesity and overall childhood health. So your talk is focused mostly on the output side, on the physical activity side. But I'm just wondering if you could comment on that, on where, and also on where where you feel our relative efforts need to be for childhood health.
Well, I'm a physical activity person, so you know where my emphasis and so I start that because I'm going to be biased towards physical activity. In most of the developed world and developing world, the balance between the emphasis and the money that goes into diet and nutrition versus the emphasis and money and resources that go into physical activity, it's about, I would say, about a 10-to-1 ratio, maybe 8-to-2 ratio in favor of nutrition and diet. You go look in Canada at how many people are paid by the federal government to deal with issues of nutrition and diet and food versus how many people are deal with issues around physical activity, sport, and health in that way. It'd be 10-to-1 ratio at least in favor of diet and nutrition. And same with research funds. So I would say that the balance has been in favor of diet and nutrition and not the other way around. But again, maybe a biased view and just sour grapes on my half. I think that both, with that being said, I think that you can't say that the kids should eat well or be active. They should eat well and be active. And they shouldn't smoke. So I don't think that we need to say that we got to focus on diet, we got to focus on physical activity, we got to focus on a healthy child. And a healthy child does all of the right things, or most of the right things, and not just be active. Same thing I said, a child that's getting lots of moderate to vigorous physical activity is not necessarily active enough. They got to work on their sedentary behavior as well. So I don't like to have this battle or war where we say diet is more important than physical activity, and physical activity is more important than smoking, and smoking is more important than alcohol, and alcohol is more important than drug use, because I think that we just end up arguing and bickering amongst the researchers about where the money and resources should go and where we should emphasize. I just like to think that we have to have healthy children and focus on the whole child and not one thing or the other. So I didn't answer your question at all because, again, I would say give all of the money to the physical activity people and everybody else can suffer. But I think that we do need to focus on the whole child, and all behaviors are important. And we could all bicker and argue about whether one is more important than the other, and I don't think that actually gets us anywhere, other than gets us arguing with our friends in nutrition and substance abuse and smoking.
Well, I think that's a great way to end about the focus on the healthy child. And that's certainly the mandate of ECHO and CHRISP, and especially in terms of our region. I really want, where'd you go? Oh, there you are. Sorry. I really want to extend our sincere thanks for a wonderful presentation. I certainly learned a lot. And we just want to give you a little token. And since you're a Laurentian alumni, I hope you don't have this yet. No, it's not. Yesterday, he got 3 water bottles. But I don't know if you have the book yet, but we thought you might like to read up a little bit on Laurentian history, written by Laurentian profs. So thank you very much. And I would invite you now to have I think it's called the Energy Boost. So hopefully it will help hike us up for the next round, which will start at about 10:30.